Thank you very much for asking us to present our data today. So I wanted to talk to you a little bit about our poster presentation, which focused in on using the Buhlmann point-of-care device for fecal calprotectin and infliximab concentrations. So our study was taking patients that had a loss of response on infliximab and assessing how the point-of-care device would function in this setting. So we had patients that were losing response contact the IBD nurse in our clinic, and they came in with a sample of their stool. And what they did was we were able to get the results back within an hour. So we had their fecal calprotectin results and their infliximab concentrations within an hour. And so we were able to make treatment decisions based on those levels, which I thought was very helpful. And so what we found was that in about 50% of patients, they actually had a low trough level of infliximab and a high fecal calprotectin, indicating that they had active disease. And in these patients, we were able to dose optimize them, and the majority of them did well after about 12 weeks after the dose optimization. What was most interesting, I found, was that 30% of the patients actually had a normal fecal calprotectin and a normal trough level, indicating that they had adequate disease control, that they had no active inflammation, and those patients ended up doing better on their own without any change in management after about 12 weeks when they were reassessed. This perhaps indicates that they likely had some degree of irritable bowel syndrome as opposed to active inflammatory bowel disease. The remaining 20% of patients had high infliximab trough levels and high fecal calprotectin, meaning that they had active disease despite optimal trough concentrations, and those patients were switched to another class of medications. And the majority of those patients ended up doing better on a different class of medications. So overall, what we found was that using the point-of-care device, we were able to optimize treatment for our patients. We were able to dose optimize in the correct conditions. So perhaps the most interesting part of the study was this 30% of patients that had a normal fecal calprotectin and a normal trough level, indicating that they had likely irritable bowel syndrome and would not benefit for dose optimization. So I think using the strategy of the point-of-care device will actually be a cost-effective solution because you're avoiding a lot of patients that may potentially be dose optimized. Thank you very much.